So, good morning, everybody. My name is Dr. Brenda De Mello, and I represent a Tanzanian NGO called CCBRT. And that's why I was going to ask you for more time, because I need to tell everybody what CCBRT means. But I'm going to save time and ask you to just check on the website, and you will find, our website is not as flashy as the work we do, because we do some really good work there. The three main components are disability, we have a maternal health program, and we also have an advocacy program, and a cross-cutting, and each one of these is embedded a really small but meaningful community program. One of the things that I feel very much, today I represent the perpetrator of the crime. I'm a Tanzanian doctor, I work in the settings, and I do completely I do acknowledge and I do fight for zero tolerance, because I think there is no justification, however poor we are, for any form of disrespect and abuse. And I think what you will see here is our efforts and our commitment to try and change the situation. And we have a unique opportunity of working with the providers. CCBRT is working with two of the main patient demographics, the disabled people and women of fistula. And these are victims of the most horrific disabuse and respect, and hence equity and respect is our key working principles. In 2009, the CEO made a commitment to the women of Tanzania, represented by this woman, that we would do all that we could to ensure that the future for women like her, that she could look forward to childbirth without fear of loss of dignity, without fear of death, and without fear of disability. And towards this, in this presentation, you will see our efforts over the past 4 years, and which we have implemented a capacity building project in the region of Dar es Salaam that involves 16 public health facilities and involves about 80,000 deliveries a year. When I say we, I mean the maternal team at CCBRT, as well as our implementers, the regional and the local health government. I work alongside the nurses, and this project has been funded by the European Union and CBM. So I call this picture One Woman, One Bed. This is a photograph I took in April 2010. And I think just at it, if you're in the ward, it feels worse. And you can actually, it oozes out every violation of the RMC Charter. But what you do not see, or maybe you can see, is the fear on the faces of the women. And what you cannot see is the disrespect that they will be, and the abuse that they will be subjected to during their time there. One of a really a low point is when I maybe a sign of my naive attempt to do something about it is I thought perhaps if we put some chairs, we could get the women off the beds onto chairs and have one woman, one bed. And so I mobilized some nurses to go bed to bed, woman to woman, asking them what they wanted and what they felt about the bed space. And what they said is they wanted, could they be 3 in a bed? Maybe could they be 2? Not one asked for one bed for themselves. So I think we have a long way to go. Where do we begin our efforts at advocacy? And how do we get women to want more? And how do we get them to know that they deserve more? This is the solution. But I feel like childbirth is a time of that a woman is elevated to an elevated physiology and partaking in a very sublime act of creation, and she should be protected and pampered. But what I want for her is a bed. I want her to be covered. I want her to be respected. I would like her to have a companion, but I would like her to see a nurse every 30 minutes, informing her, responsive. And I would like to hear the sounds of competency and efficiency. I'd certainly not like her to die. And I think the big challenge is trying to, when I painted this picture in a group right in the beginning to a group of providers, they actually looked at me with disbelief, and there was tolerant laughter. And I remember, but I would like to say that this has been a daily message. From 2010, we've been singing the same song, and it underlies every investment that CCBRT has made over the past 4 years. And I strongly believe that what you don't get because it is your right, you will get because you're persistent. And what I would like to take you back to the picture, but I think this is a more positive image, so I won't take you back. So in the first few months, I couldn't get people to listen to me, so I actually went into the ward and started working alongside them, learning, looking at their challenges, understanding the situation, and just trying to earn some brownie points, helping them with their maternal complications, and that is really a big need. What I've found is that the shortage of staff is extreme. The picture that I showed you, they do 60 to 80 deliveries a day, 22,000 deliveries a year. On a shift, they have 2 to maximum on the morning shift, 3 people. It is impossible for the nurse to do anything other than respond to the emerging head, which means that sometimes others are abandoned. And apart from that, the lack of skills is shocking. They do not know how to do a shoulder, and they do not know how to do a vacuum. And they think they can scare the baby out of coming out of the birth canal. I call it beating the baby out of the mother. And I joke about things like this. Not joke, because you need to make it light, because it's too depressive. And so when I teach them, I say, look, you cannot beat this baby out of the mother. But there are other techniques, and let me show you how. So they are seriously, one of the contributors is the lack of skill, which sometimes gets masked by aggression and arrogance. And I think this is something we need to recognize. And and that's why I appreciate that engaging in a capacity building project helps us to address both of these. Apart from that, there is seriously low pay. And many of the nurses, they sell their days off to compensate for the low pay. So they are extremely exhausted and burnt out, so used to blame and looking at death, multiple deaths every day, that the only way they can get up in the morning and go to work is if they harden their hearts. Now, this is the disrespected and completely disempowered workforce that we expect to deliver this care that is kind and genuinely, the smile is in the eye and the touch is gentle. But that is what we cannot lower that vision. We cannot lower that vision, but we have to be creative. And I think one of the things I've learned is that they need to know that we care about them. They need to know that we understand them. They need very, very little to be motivated to work better. And I would put it to you as actually they care a lot, because in the workforce in Tanzania, we have had doctor strikes, but we've never had a nurses strike, because they know that if they do that, it would be disastrous on the maternal mortality indicators. So what we did do is we planned with the local health government, and we looked at their budgets, we looked at what we had, and we saw what we could take off from the budget, trying to negotiate, well, could you put the budget that you've now released into buying drugs, supplies, and motivating? When we first started, they didn't even think that the nurses needed motivation, but because we reflect, these pictures I've used at every forum, they now, at least 10 of our sites are giving nurses extra motivation from their own budget, because we cannot use donor funds to do that. Where's my next? So the strategy we adopted was twofold, mainly because we couldn't invest in having more staff. We were looking at decongesting. We wanted to decongest the 3 municipal hospitals. So Dar es Salaam has 3 municipal hospitals that do 70% of the deliveries. And that was one of the pictures you saw earlier on. So as part of the health sector reform, they were commissioned to improve and engage and build capacity in the primary health care. So this was part of their plan, so it was very easy to get buy-in. So we added on 16 sites that we were building capacity, and the hope that these 13 sites would absorb some of the low-risk cases and help to decongest the 3 municipal hospitals. And simultaneously, we started fundraising to build a tertiary level center to upshift the more high-risk cases. So these are the facilities that we are working in. What we started with is we invested in a capacity building project, learned from the literature, the AMDD building blocks, and there was good buy-in for this, because reducing maternal death and preventing neonatal death is a country priority, and they really have to do it. We have extremely high facility-based deaths in Dar es Salaam. So getting buying in for this was very easy, and what we've done is linked on caring for the provider and trying to create a culture of change and culture of kindness along with the capacity building project. So at the core, you find our main values. So we have actually introduced the component of maternal-friendly care for people with disability, because that is also one of our pet, the origins of our hospital. We do a lot of training, and I know training per se, when we do the before and after, causes very little change in behavior. But what training does do, it allows us interaction, and it allows us an opportunity to influence. So, and the providers really love training. So, we give them what they need, and we also influence them into a behavior we would like. So we talk about disability, we talk about respect, and fortunately the training package that we're doing is based on the standards-based management approach, which we use for training as well as for assessments. And I recognize Jopaigo's work in this, and it's competency-based, and it has the ingredients of respectful maternal care included in it. And so that makes it very... I'm very a big proponent for integrating these kind of modules. In the training, we've also managed to stimulate the quality improvement team. So each of our facilities has an invigorated quality improvement teams, and we spend a lot of time working with them. One of the modifications to the training is we are trying to influence the heart, and that you cannot learn in a classroom. So we do involve some of our ex-fistula patients. So patients who had fistula who were cured at CCBRT and are in the rehabilitation program called Mobility. So every training we have, we ask 2 ladies to give their testimony. And what is really powerful is the fact that these ladies deliver their testimony with amazing grace. They sadness and loss in their voice, but there is no condemnation and there is no anger. And that makes the story all the more powerful, because the person who's listening is very often one of the person that comes from the site in which this lady was, and they feel so uncomfortable. There's not a dry eye when you hear the story, and I've done this for 4 years, and I bawl my eyes out at every hearing. And at the end of it, I do a public apology. I make all of us apologize to the woman. It's very emotional. It's very emotional, because what we do is, on behalf of all other providers and the system that failed her, we say sorry. And then to make it better, we recognize champions. So we find one small thing, we make a big deal of it. So I call it magnifying successes. Thank you. So we, at every opportunity, so we have Rose, we did a big ceremony for her. She did 625 deliveries in 3 months, 2 years in a row. So you can imagine, I don't know, in a 40-hour shifts how that is possible, but she is a widow with 4 children, and we got a private hotel to offer her a lunch for her and her family. The other girl, Hadija, you can't see her, is very happy with her protective gear. She scored 100 on the assessment test. So we look for the most proactive manager, we look for the best provider, we look for any best practices. We organize a little meeting and we make them share, and just trying to praise and infuse some hope, because I think that was also in great shortage. But one of the key steps is what we looked over time was the thing that we learned is that there were some sites that did better than others. And so we looked and learned from them, and we found that those sites had the managers that were the most engaged. And one of the sites is Buguruni, another site is Chanika, another site is Amana, and you could see a significant difference in the standard and the sustaining of the improvement. And so I think managers are the key. So we now, for the last 1 year, have made a lot of effort in building up leaders and managers. Coincidentally, at that time, CCBRT hired a lean coach. There's a young man from Ireland, and he is revolutionizing CCBRT. Well, I managed to sell him my project, and he volunteers his time to work with me. So now in the region, we have 15 managers being trained in lean, and all it teaches them is to get off their bottoms, leave the office, go into the ward, go and see, talk to the people, observe the work, ask why, show respect. And that is completely revolutionary, because now there's a maternal death. I say, ooh, this has happened, but please, I want to go to the root cause of it. And they said, don't worry, Brenda, we're going to go and see, we're going to ask questions, and we'll figure out a way so that this doesn't happen again. It is early stages, but I think this is the key, having a manager that cares, and they can control. Most of the sites that have allowed the night duty staff to have an extra motivation allowance come from the managers that care, because they can authorize cost-sharing money to be used for overtime. So this is a key cadre that I'm going to be presenting to you as one of a potential potential conduit for changing of culture and changing of behavior. The other thing that really helps is investing in infrastructure. We had the money, and so we did it. So we are very strategic about the projects that we took up, and that's in the 6 months I had listed the priorities. But investment in infrastructure just lifts up the site significantly, and there's a positive air around, and it is the greatest way to buy in managers. So it's kind of buying in the influence, because now I have a seat at the table and they know it's like a commitment that you really care about them. So we've renovated 2 maternity wards, we've done 3 theaters and a postnatal ward. So we had a little space. So after we invested in one, they found an old kitchen, and it took about 6 months of advocacy to say, do we want to eat little mishkakis while there's a stillbirths being collected out there? And it took a little bit of that, and they gave us a ward. We got the funding. We've made a KMC and a postnatal ward, because you cannot add more beds in a crushed ward. You just have to find more space. We've put in curtains, because that, again, is too much for a minimum budget. And, of course, because, again, in commitment to our core client, we've put in ramps and put in disability-friendly toilets, as well as we are training on sign language. So we train in sign language. The proportion is very poor, but each interaction with the healthcare provider teaches them about disrespect, because thinking about disability is about thinking about how not to disrespect. What do we measure? So we measure, again, we means the quality improvement teams, every quarter, measure the routine indicators: maternal mortality, total deliveries, live births, maternal mortality, stillbirths, neonatal deaths, cesarean section, low cavity vacuum extraction. The joint management teams, we do the standards-based assessments every 6 months, and we have quarterly meetings to share the results. We have a focal person who does monthly meetings at the sites. There's every quarterly meeting, everyone gets to share a best practice, and one of the sites have had the managers put on duty, overtime duty, and they assess 2 people on the duty roster on the assessments routinely. So there is a continuous assessment. This is exactly what we want, because we want it to be not something done when I come. And that is one of the weaknesses of the tool, is that you do get a significantly improved quality of care when you're in the ward. And we do a lot of celebrating success. Any little victory is amplified. So these are the standards. We have them for each site. And while they measure clinical care, they also measure the respectful component. And I haven't done detailed analysis of this, but very easy to tell that the weakest link is the respectful components. What it doesn't measure disrespect. So that is one of the issues. And one of the things that I would mention, I think it's really important, because this is a gap that I think is happening. There's an assumption that disrespect is taught, is known. But in medical school, you get taught what to do. You never get taught what not to do. And I think this is a fatal assumption, and it needs to be addressed. As a region of Dar, we started at 9%, and now we're at 55%. Very, very slow progress, but at least because the graphs are going up, very little going up, going down, we are quite happy. So you can see Temeke municipality has done a big dip. But again, when they see this and they compare it against the neighbors, there's a little bit of healthy competition going on. Success story, some of our lower volume sites, they were doing less than 1 delivery a day. Now they're packed. So we have health centers doing 3 deliveries a day. We have some doing 10, some doing up to 15. And in these sites, in like Buguruni, you can get 1 woman, 1 bed. I mean, that is such a low vision, but it's such a big victory. And in this kind of site, you will get a more respectful care. So at least it is very, very encouraging. We have more data, but I'm going to try and keep time. In terms of what is happening to the mortality, I think this is critical, because this is what the country is looking at. It is, I mean, in the volume, it is almost negligible. 14, after 1 million euro, we have reduced 14 deaths, 60 deaths, but thank God, it's not more. I'm quickly going past that slide because I'm so embarrassed. But we are tracking, because we need to keep ourselves accountable. For every death, we need to make sure that we are addressing it. I'm on track. So last this is the hospital that we're building. This is the CCBRT Maternity Hospital. It's work in progress. The management of this will be at least more influenceable. They're being trained. We are going to start, building towards it. And in this hospital, I can assure you that we will have respect for maternal care in every protocol, in every training. And that is something we can control. What I would put before you is I think what we have done in 4 years is actually maybe just create the hope that it is possible. We haven't really got there. Of all the achievements we've done, the weakest is on the aspect of respect for maternal care. So I think it is really timely that this topic is coming up. To introduce it before you introduce a capacity building project, you might not get the leverage that you want. But now we're ready. We've actually set the stage. And I can assure you that you will not, I hope, that you will not get the defensive behavior that you experienced, Mary Ellen, because we're ready for this. We've heard it, we're ready, we acknowledge, and we're not there yet, but we are ready, we're on the train. I think what began as a capacity building exercise is now I find myself more engaged in leveraging for respect for maternal care and for improved care. And it just gives, and I find myself having to be a spreader of the message that we are not too poor to cover, to show compassion, to greet, I think, and to treat our patients with kindness. It is not a resource limited problem. And I think that our women are worthy of getting the whole package of good clinical care as well as respect for maternal care. I think now what we need to think about is how can we get the women to want more? How can we create awareness of their rights and get them to be a little bit more demanding? And I would also like to throw into the pot the consideration that maybe training the leadership and managers into a cadre that cares could be a way of influencing the culture. And this would, they would have the most sustaining effect on the provider who ultimately will be delivering the service we desire. I would like to end with a quote from Dr. Edward Deming. A bad system will beat a good person every single time. So we need to make sure that we invest in the system because that will be where the cure is. Thank you very much.
Wow, bravo to all three. I'm sorry I've been the time lord here, but I think these were incredible presentations. We got a lot out of them, and I think we can all agree that it's worth taking some time from our break to probe these conversations a little bit deeper. So we'll have 20 minutes of Q&A and discussion in the audience with these guys. So Mary Nell, do you want to take the mic and...
Could I steal this mic? I don't know where the other is.
Yeah, we've lost a mic. Oh, there it is. Okay.
So we have Mary Beth and then we've got Martha.
Okay.
Thank you so much. Those were excellent presentations. I just wanted to, because Ariel, your presentation, and Brenda, yours, I'm wondering if there might be some marriage between the two and how, Brenda, you think that would affect the relationship with your hospital or with your clinics if the community is involved in accountability work, and Ariel, maybe your reflections on how focusing on certain leadership in these clinics can be useful for citizen accountability efforts. Thanks.
Yeah, let's take 2 or 3 at a time. I think that works well, if people agree. You guys ready for that? Yeah.
Thanks. This is actually a direct follow-up to that, linking the two presentations. I was curious, Ariel, given Mendy's comment about the challenge of, increasing challenge to actually assess what the impact of this work is on maternal health outcomes or in other areas, I was curious, Ariel, in terms of trends that you've seen in the project over time in terms of not necessarily maternal health outcomes, but trends and outcomes in service, in use of services, or what you've seen there in terms of the the impact of the project at the local level.
Another question before I turn it to the panel? Yes, John.
The issue of disability is becoming more important in lots of areas, and it's the first time I've heard it in this meeting. From the other two groups we've heard from Tanzania, how is disability addressed in the context of these changing policies and plans?
Okay, panel, I leave it to you to take these questions up. Ariel, do you want to start with the disability question with John's and go backward?
You want to begin?
Yes. Okay, Thank you very much. So I was asked about what I think about the citizen participation. I think when he gave his presentation, I thought, oh, that is exactly what we need to do, and I need to learn how. So because our house is so dirty, in terms of like there is such a lot not going right, it might end up in a revolt. So maybe we need to do a little bit of house cleaning, and then find out nicely how you start the process without it becoming, a riot. So to train the duty bearers, the day somebody says that and they can, confidently confront a doctor, I would consider that a big victory. Every one of those, a person who is monitoring, standing up to a doctor, standing up for their rights, I think that is a great way. That's a great forward. So I think that's something, a learning lesson, and I think a necessary next step. It could be a beginning or the end, but in the state that we are in, it makes a lot of sense to think about it. Maybe about disability, it was a question for me.
For those who didn't speak about this.
Oh, good.
Go ahead, Ira.
Go.
I just wanted quickly to follow up on Mary Beth's question before I answer the disability question, that we're also finding out at the national level that many are quick to want to address the issue around addressing the demand side and issues of citizens' participation. But I think we might run into a challenge of raising expectations if, what Brenda was just saying, if we're not cleaning up the facility first and deal with the health workers and make sure that once citizens know their right and they're able to demand their right, the facilities are actually in a position to deliver the service. To answer the disability question, no, we haven't really looked at that. I just had I presented last week at Georgetown about this topic, and someone was also reminding us about focusing on women in prison. A similar question about all these minorities, which for now we're just talking about women in general. We're not really focusing on specific groups of women, which of course is something that we need to do.
Yeah, thank you. Thank you for the questions. And thank you to both of my colleagues of the panel, because they have had wonderful presentations. In terms of working more on the side of the health providers, we have been beginning to work with the health providers in terms of what comes from the dialogue spaces with authorities in terms of issues to be covered are then taken again in a more local dialogue, facility by facility, on how does that problem or things that should improve in the management reflect on the health facility. And that dialogue is run by women themselves with our facilitation with the health providers in those facilities where the teams are keen to do that. We have had the challenge of a high turnover of the health providers in general. In Peru, in the rural areas, there's a high turnover because of the working conditions of the health providers. They just take the rural work as less time as possible. It seems this is going to change, because the part of the story that I didn't talk about is we have been working also with the Ministry of Health on human resources policies, and the Ministry of Health by itself has had this initiative after a while of working on this, and this is one of the components of the health sector reform, the human resources policies, and it includes incentives to the workers that are working in the rural areas, and it includes, or is supposed to include, some improvement of the conditions of work. This is still going to happen, but I think it's very important for us to demonstrate the providers that we are with the same goal, and that is the way we begin the dialogue. We have the same goal: improvement of the health of the people that are under the facility, and that we are just providing our views. Providing the views, women are providing their views, because that's the first principle of quality, client orientation. So we do think that we would have it would be great if we could have something like what has been presented, like a vitrina, like a window to see, how things could be different, like a demonstration space. That will be great. And I'm thinking that we work with champions within the facilities. Most of them midwives and nurses and some medical doctors that are now convinced that this is a way of dialogue that should happen always and that should be institutionalized. The winning that has happened along these years has been the creation of the space of dialogue, which didn't exist, and the recognition that what women are asking for, and we always repeat this, is whatever they would expect for their daughters, for their wives, if they go to any facility. So we're trying to get that common language between them. It's not easy. The turnover is always making us, also the authorities, making us begin again in many environments, but we are on there. And now nobody questions the existence of the dialogue spaces, which is a big winning from us. In terms of the trends of working on maternal health and child health and how this reflects another user of the services issues, it's absolutely true. Because when you analyze what is not functioning, that applies to all the users, to all health services users in general. There are specific things for that happens in pregnancy and labor, which are very hard. But there are also many exclusion and a lot of discrimination happening to all health services users. So that's why we have identified, even with the same providers, the issue that many things are not responsibility necessarily of the local facility or the local team, but are reflection of many things that are happening in the health system. It has also given light for us of what happens with other social programs, for example, conditional cash transfers. They give money to the families, the poorest families, and as an incentive to go to the health services. But the program finished there when the families receive the money and show the registry that they have gone to the health facility. What was happening with the beneficiaries of the conditional cash transfer was that they didn't receive a quality health care. They even sometimes didn't receive care. They just received the seal that they have been treated because they come in trucks from the forest communities, and there are a lot of women and people to be attended, and the local team, they don't get organized, and they even don't claim to the upper level, so they just seal the paper as if they have received the health care that they don't. So we have given light to many pitfalls of some social programs like that. We have identified the exclusion of the public insurance for any person that has a microcredit. This was a decision of other ministry that if they have a microcredit, they should be excluded from any other program. And that was ridiculous because many people have microcredits just to go out of the poverty, incentivized by other programs. So the possibility of a local view from the side of the people give us the tools for advocate for changes and to give light to pitfalls of the system in very short time, because we have real data on that. So it is not only for maternal health, it is principally for maternal health, but it's helping us with social programs and other programs. And in terms of disability, what women choose to see and analyze in the health facilities is their own prioritization. This, on the basis of their rights, they prioritize 5 or 6 main things to cover. But they also prioritize what messages to take to the community. And one of the main things that we work with them under the framework of rights is the importance of those who need more attention from the community itself. In rural communities, in the Quechua people, widows and disabled people and elders are almost the most forgotten. And although we have not have a systematic approach on that, there are like from the 15 districts we are working in, there have the issue of disability and how we could facilitate a more close approach of the team to the disability, to the disabled people in general, has appeared at least in 4 or 5 districts.
Okay, we've got about 6 minutes left for any more questions. Eva? I know. I was coming. Eva, you want to go, Eva?
Yes, thank you so much to the presenters. It's been so thought-provoking. And so I was just thinking about quality of care frameworks and the standards-based quality of care approaches. How should that be changed, or how can that more easily emphasize respectful maternity care? I think if we look at quality of care approaches, since for many years they've always included respectful maternity care in some ways, but it maybe hasn't been so salient. But what do we need to do differently in the future to really emphasize respectful maternity care? Thank you.
Thank you, Eva. Laura?
Thanks. I've just been thinking about maternal and perinatal audits and how they've been increasingly adopted as a way to improve the quality of care. And I'm just wondering if the 3 panelists could mention whether they have been used in terms of at least looking at cases of neglect. Abuse might be hard to document in a perinatal audit, and we certainly don't want to use the perinatal audits as a blame game. But can we use them? Is that a way to start maybe documenting some of the improvements and some of the associations between neglect and maternal and newborn mortality?
Okay, I'm going to leave the panel with those 2 questions in our last 5 minutes. Who would like to begin?
So maybe the one about the perinatal audits is a little easy. There's a great resistance to conducting audits. They don't want to do perinatal audits, and it is confidential. So one of the things, just taking the data of the number of stillbirths, what I do want to look at is the number of stillbirths per shift per day. And I wanted, the nurses to look at the data on a regular basis. So they do look at it, but they don't want it to be on the notice board, because they say, what if a newspaper person comes and sees it? And I think, so what if a newspaper, because this is a true reflection, but they're not, because they know that if it gets out and if it comes in the newspaper, somebody loses their job. And there's a quick transfer of patients, people around, that really doesn't solve the problem. It just spreads it to another area. So audits, we've not been successful in that. Maybe just one side is doing it. So again, we're just trying to get the buy-in to do the audits, and we're still trying to come up with a methodology that is easy, because all the ones that I looked at are too complicated. So it needs to be something that they can find something to work at the end of it. What do they do next? So I don't have more answers to that. In terms of the standards-based approach, maybe what I could say is I'm glad that it's included, but it's already a very long tool. And that is, and I justify, I agree that the tool is so long because we're starting at ground zero. Because a lot of the things, you take for granted, but they're included in the standards, like greet the patient, call the patient by name, tell the patient your name, talk to the relative. These are all in the standards of care, which sounds so, why would you put them in a standard? But amazingly, that's the one that's the weakest gap. Right now, I feel that because disrespect and abuse is there, and it's getting, and we are, I agree with the zero tolerance. It may need a little extra effort, and that respect and disrespect are linked but not the same. So you need to add on the disrespect to the respect for maternal care portfolio, and kind of do a little more advocacy, maybe at the school levels, and like a little sub-intervention, because it is actually quite easy to address. And I must admit that before I met Mandy, I didn't know about the charter. And I'm sure my colleagues in the Ops and Gyne, AGOTA, the Tanzanian Organization of Obstetrics and Gynecology, have not heard about the charter of RMC. So those could be very quick wins. And I really do believe that when you see it in the mirror, when you see it reflected, you can actually, it feels bad. And repetition, it could be the beginning. That's the journey. So we'd have to work something out like that.
Monday, can I give you the last word on this topic?
Yes, I just wanted to add on what Brenda was just saying about the tools being too long. I think what we also need to take into consideration is that we need to stop just focusing on healthcare providers and midwives and nurses and doctors, because some of the disrespect has also been reported that is done by guards, or what Brenda was saying, focusing on new cadres like managers and others as well. So just an addition to what we could do differently.
Okay, Ariel, I'm going to cut it off there. I hope that's all right. We're cutting our break short 10 minutes. I want to give it as much time as I can to you. So we'll be back here at 11 o'clock. I know these three have lots more to say, so I would encourage you all to corner them at the coffee table and learn more from their wisdom and experience. We'll be back here at 11 o'clock. Lots to do, so let's be prompt. Thank you.